Good evening, everybody. Welcome. I'm Boalem Bousloub. I may appear as Sharon Corkin. My computer went on strike, and I had to hide behind my wife. That's the whole story. So welcome all of you. And I would like to start by thanking our program director, Lena Kennedy, who is handling everything in a magnificent manner, and I salute her.
Amen.
I want, among our guests, I want to start from saluting way from Dakar Plateau. We have, and we should have, Councilman Sheriff Sumari. And at this hour, it is 3:00 in the morning there.
Wow.
Oh my goodness.
Yes, he registered. I know that most of the time he attends, so I don't see him, but he will appear, I'm probably sure. I want also to salute our Councilman John Kennedy. He told me this morning that he will come and he will be here, so I'm sure he will appear. And I would want to welcome Dr. Sharif Keita from Wisconsin, who will be our August speaker and will be introduced by Deborah Mindry here. So we have a link. At this time, I would like to introduce the MC of the evening, who will introduce Dr. Mindry and will deal with question and answer. So here we go about Dr. Aisha Randall. She's a tenured professor of learning skills and education at the Los Angeles State Technical College, where she served for 22 years. Currently, she's a college faculty coordinator responsible for the implementation and coordination of the college accreditation. She also serves as advisor for the Umoja community, a student group dedicated to fostering the academic success of African-American students. As a department chair of the Learning Skills Center for 6 years, she managed $1 million budget, 5 disciplines, and a team of 75 faculty, staff professionals, and peer tutors. She's a volunteer of the community in many ways, but I just selected one. She's a Girl Scout troop leader of a group of 25 girls from 6 to 17 years of age. And that's one of the reasons we were very happy to welcome her as member of the committee. And to conclude, her degrees are Bachelor of Arts in Interdisciplinary Field Studies with emphasis in African-American women in film and television from UC Berkeley. Master's degree in education with a concentration in psychology and technology from Harvard University. And finally, a doctorate in educational leadership with concentration in motivation and learning from University of California, USC. Welcome, ask you to join me. Welcome Aisha Randall, our MC.
Thank you so much. Thank you very much. Good evening, everyone. I hope that you are having an amazing Thursday. We're so happy that you are joining us tonight. Wow, I'm so honored to introduce to you Dr. Deborah Mindry. We had such an amazing talk today, and I'm just astounded by the work that she has been doing in the area of public health, HIV, and AIDS, and work around how to change sexual reproductive health services so that they are more inclusive of men in these types of, in certain settings. I honestly had not put in a lot of thought about this subject, but in talking to her, I learned a lot, a great deal, and it is extremely important if we want to get a handle on lowering the numbers and creating an environment where men feel welcomed, not judged, cared for, because that's the society that we need. Dr. Mindry grew up in South Africa and could have just gone to school and just chosen a different path, but she chose anthropology and has been doing deep and thoughtful, very thoughtful and courageous work in the area of ethnicity.
Okay, can you hear me? Uh-oh.
I can hear you.
And so she's been doing this great work and working with a lot of African people, men in particular, making connections and helping them to get their voices heard. Just really remarkable work. And she's not only doing this formal work that she's being compensated for, but she's also mentoring students and helping them along the way. From our conversation today, I really felt her heart for people, for justice, for mentoring. And right before we started talking, she shared that she had been mentoring a student from Johns Hopkins, a master's student in public health. And so I just want us to realize that people like Dr. Mindry are so valuable because they're willing to give a part of themselves and to see others to succeed. And it's easy to do research, write articles, bask in that glory, but it really takes special people like Dr. Mindry to make it easier for the next generation to go to college and reach their goals and do what they're really passionate about. So I'm really honored to introduce her. I'm going to now read to you her formal bio. Reproductive justice for people living with HIV. This is what she's going to be speaking about today. Lessons learned from research in Africa. Born and raised in South Africa, Dr. Deborah Mindry is a research anthropologist with the University of California Global Health Institute. University of California Global Health Institute, UCGHI, a UC-wide initiative that stimulates, nurtures, and promotes global health research and education. Deborah Mindry, she, her, hers, Dr. Deborah Mindry's research interests include gender politics, non-governmental organizations and development, sexual reproductive health, and HIV/AIDS. She has conducted qualitative ethnographic research in South Africa since the early 1990s. Her research examines HIV, reproductive health, and gender dynamics in South Africa, Malawi, Uganda, and the United States. She is currently working on a book manuscript, I Am HIV, Ordinary People Daring to Live and Make Change in South Africa, which challenges conceptions of Africans as victims of HIV, arguing instead that it is people on the ground who are figuring out how to live with and thrive with an infectious disease. She is an extraordinary international spokesperson for women and has great compassion and courage for her convictions. Please help me in welcoming Dr. Deborah Mindry.
Thank you so very much, Aisha, for such a lovely, lovely introduction. And it truly was a pleasure speaking with you earlier today. I'm going to jump right in because I want to make sure that I get through the talk with plenty of time for questions, because I think there is a lot of interesting stuff that can come out in informal discussion. So let me share my screen. Okay. All right. Oh, sorry. I think I've got to stop the share in order to get it full screen. Sorry about that. Okay. Nope, it's not going to let me quite do that. Looks like I have to do it where you're going to not see it quite the way I'd like. But anyway, so here we are. I want to just point out with my introductory slide here, this is actually a picture from the Osui region in Senegal from a time when I went there and we were having a meeting with people locally. Okay, oh, I am having, no, let me see. Ah, there we go. You're seeing my screen now? Good, okay. All right, so just to introduce you to some of the areas, just some images of some of the areas where I've done my work. This is actually in my family's backyard, as it were. This is the Valley of 1,000 Hills, just inland from Durban in South Africa on the East Coast. And this is a photograph taken from one of the clinics that I was working at above the valley, looking down into the valley. These are two of the sites that I've worked with partners from Rand Institute and from Makerere University in Uganda. This is in Jinja and in Kampala. We worked in a number of other sites as well. And this was work that we were doing on safer conception counseling for couples who are affected by HIV. And then another site that I've done a good amount of work at is with partners in Lilongwe and Koma in Malawi, doing similar work. I've also worked in Rwanda, but not on this particular kind of work, on other projects. So let's start off here just by looking at the global adult HIV prevalence rate. This is from 2019. Sorry, I've got an error up there. It should be 2019. Globally, we have close to 38 million people living with HIV. You can see the greatest burden is in Southern and Eastern Africa, with 20.7 million people living with HIV in that region. Whereas in Western and Central Africa, we have 4.9 million people living with HIV. So people often talk about HIV as being a problem in Africa. Well, it's a problem all over the world, but the biggest problem is Southern and Eastern Africa. Let me start here with some key pieces of information. I'm not going to bore you too much, but there globally, since the start of the pandemic, 77.5 million people have been infected with HIV. And as I said, now we have about close to 38 million people living with HIV, meaning the others have died. They are no longer living. We have lost close to 35 million people to AIDS. The wonderful news is that the annual AIDS-related deaths have decreased by 61% since its peak in 2004. And in 2020, there were 1.5 million new HIV infections worldwide. So we continue to struggle to get this infectious disease under control. And 27.4 million people who are living with HIV are now receiving treatment globally. They're receiving antiretroviral therapy. So that is really good news. There's still a gap. We still have 10 million people not receiving treatment. And part of the effort of UNAIDS is to try to reach the goal of what is referred to as 90-90-90, meaning of the number of people estimated globally to have HIV, we want to ensure that 90% of those people are coming in for testing and knowing that they have HIV. Then we want to ensure that 90% of the people who test positive for HIV go on to treatment. And then of those people who go on to treatment, we want to make sure that 90% of those people have are staying on treatment and therefore getting their viral loads suppressed so that you would no longer detect HIV in their bloodstream. That goal was supposed to be reached by 2020. And that effort was in order to turn the tide so that the number of people becoming newly infected is less than the number of people going on to treatment. So we want to turn the tide on that. Right now, we have reached a level globally where 84% of people who have HIV have tested and know their status. 73% of those people are accessing treatment, and 66% are virally suppressed. So we still have a ways to go, but we're getting there. I wanted to also give you just some comparatives from Senegal, which is where our sister city is, and from the USA, where I've done a little bit of work, but not a lot, and the 3 countries where I've done most of my work, South Africa, Uganda, Malawi. So you can see Senegal has a very low HIV prevalence rate. That means the number of people living with HIV in the country, 0.4% of the population. We do not have that data for the USA. They stopped producing that data for the USA in 2011, 2012. But if you look at the number of people living with HIV in the USA compared with the total population, we're at about 0.3, 0.4, 0.3% in the US. South Africa has one of the largest burdens globally. 19% of the population is living with HIV. In Uganda, 5.8%, and in Malawi, 8.9%. And there are the raw numbers of the number of people living with HIV in the different countries. In South Africa, it is a massive burden. And then ART, that's antiretroviral treatment. You can see the numbers there. We've done a great job in many places getting people on treatment. Again, this data is not available for the US. And the last line gives you the numbers of new infections in those countries in 2019, for the year of 2019. Oh, the other thing I wanted to point out with the USA is you will see that that 40% of the people living with HIV in the USA are African American. And this is a real problem, and I'm happy to address some of the issues about the healthcare disparities. I'm sure many of you will have some ideas about why there would be such a disparity and why a larger number of people than is representative of the number of people in our population who are African American living with HIV. And just again, because we're US based, I decided to include this representation from the CDC's website of the distribution of HIV infections. This is new HIV infections in the US in the year 2018. And there you can see the different categories. And by the way, I will be making the slide presentation available so that people who want to have some of this data and information available following the talk, you will be able to get it. So don't worry to scramble. All right, so one of the things that I want to draw our attention to is that what the HIV pandemic did was really dramatically shift our discourses about sexual health. It drew our attention to the effects that stigma can really have on sexual health. Because there's so much stigma around talking about anything to do with sexuality and sexual health, this has really been one of the things that has been a barrier to getting people to come and test, to getting people to go on to treatment and to adhere to treatment. People are very afraid of the things that people will think of them, of partners who will leave them, of people who will beat them because they have transmitted, and really gets in the way of ensuring that people are receiving the health care that they need. The other issue that the HIV pandemic made us acutely aware of is discrimination based on sexual orientation, race, and gender, which impacted people's willingness to come forward to test for HIV, to engage in prevention activities, to get treatment, and so forth. And has also really impacted, certainly in the US initially, there was a lot of difficulty in getting attention to this because it was largely in the gay community, and because of stigma against the gay community, there was a great deal of difficulty in getting people to address the issue. And in every country, we can see the ways in which discrimination really impacted ensuring the needed healthcare be rolled out. It also, however, made us aware that everyone is equally vulnerable. So as much as we might want to say, oh, here it's gay people, or there it's sex workers, or there it's Black folk, or whatever, what we have discovered is that everyone is equally vulnerable. Whether you're married or unmarried, gay or straight or bisexual, rich or poor, monogamous or polygamous, you are equally likely to get, or equally vulnerable to getting HIV. And we've certainly learned this with the COVID pandemic. And we know that because of the issues of discrimination that I just referred to, that certain groups end up being more vulnerable than others. So what do we actually know about gender and HIV? One of the first things that I found out when I started looking into HIV is that women are more vulnerable to HIV infection. And why would that be? One of the first things is because of biological vulnerability. The vaginal tissue is very delicate tissue. And so even in normal intercourse, there would be abrasions or ways in which the virus can enter directly into the bloodstream through these abrasions or sores or things like that. So that's what makes women more vulnerable biologically. But we also know that women are more vulnerable because of social norms and gendered power dynamics, that often it's very difficult for women who may be dependent on a male partner who's providing, in some instances, the main source of income, to then insist on condom use or to even know what her partner is doing. So that's why even married women can be extremely vulnerable. Their partner may be having other partners that she doesn't know about. But one of the things that we don't talk about very often is that men are actually more vulnerable to death from AIDS. And why would that be? The first thing is that men are less connected to the healthcare system, particularly when it comes to sexual and reproductive health, which is geared towards serving women. So these are not male-friendly spaces. Men don't like coming into these spaces because there are predominantly women in those spaces. And the healthcare providers orient their care towards women. And it can come down to even simple things like you'll see an image of women and children up at a family planning or a reproductive health clinic. You don't see pictures of men and children in those environments. So it can come down to those simple kinds of things where men feel alienated in these spaces. And sometimes not just alienated, actually really not welcome in these spaces. Then there are also the gendered ideologies of male power that influence men, that make men feel like, oh no, if I'm not feeling so good, I shouldn't go to the doctor. I'm a man, I can tough it out. I can get through this. And then they often come in for care at a point where they're so sick that it's really difficult for doctors to do anything for them. And this is just to give you an idea of the globally and within sub-Saharan Africa, the gender distribution of infection. So you'll see that the top diagrams are the adult population globally on the right living with HIV. We have an equal split of men and women globally living with HIV. But if we look down below, we see that in sub-Saharan Africa, there's a little bit of a skew toward women. Not a lot, but now if we turn and we look on the left-hand side, we see the diagrams of new HIV infections. And we see that globally, there are actually slightly more men who are newly infected with HIV. But if we look in sub-Saharan Africa, we see actually quite a big skew toward women who are newly infected with HIV. And here we're looking at the gender death rates. The diagram on the left is just the global death rates for everyone. The diagram on the right shows us by gender. And you can see, and if the data came through to 2020, we'd see an even bigger decline, that the decline is much greater among women, which is the blue-green line. One of the things that when I first started looking at the HIV pandemic in Southern and Eastern Africa, I was really looking at how we were attending to these issues in Africa. And one of the things that I really noticed was that, and this is in a paper I published in 2010 that I entitled Engendering Care, humanitarian aid for HIV/AIDS is very much shaped by a feminized rhetoric of caring that casts African men as virile and violent and the source of rampant heterosexual HIV transmission, and women as powerless victims who are in need of rescue, again by the West, having to come in and help African women because of African men who are having too many sexual partners and who are abusive. Now, that's the representation we see. That's the stereotype. That's not to say these things don't happen. Of course they do, but it is a skewed representation of what is actually happening. The bias in humanitarian discourses around HIV is that humanitarian discourse continues to frame the disease in racialized terms such that Africans are cast as diseased and especially needy victims of dictatorial male leaders. And it is a discourse that assumes that African women are incapable of making changes while African men are simply unwilling to make change. Rarely is there an examination of the persistent disease problems in these regions, that we have TB, malaria, increasingly we have started to focus on those, but how all these other kinds of diseases and the lack of good health care ensures that many people in these settings are already vulnerable to any infection. And we fail to examine these global inequalities and injustices that maintain these health inequities. Here is the actual gendered reality of HIV that for me, I've extracted from my years of work there. First of all, research has found that in some cases, there are more women in serodiscordant relationships, meaning the woman is HIV positive, but her partner is HIV negative. So if we have more women in Eastern and Southern Africa living with HIV, it would make sense that there would be more women who are likely to have HIV negative partners than men who would have HIV negative partners. And therefore, those women, if they are not disclosing their status, not able for many varied reasons to insist on condom use, that they're then putting their partners at risk of HIV. And there is research that provides this link, showing the ways in which men are contracting HIV sometimes from their female partners. Again, as I've talked about, men often don't show up for healthcare services until they're really late in infection stages, and that's why they often will die. The other thing we overlook, and there are one or two researchers who now and then have been honest and pointed to the ways in which they've overlooked this, is that men are often in caring roles. They get overlooked. We assume that women are doing all the caregiving, and women often are, but there are also men doing caregiving. And I was sharing with Aisha earlier today, one of the wonderful men that I worked with in South Africa, Xolani Khumalo, who himself was taking care of his mother who was dying of AIDS, and in the process contracted HIV himself. The other problem is that men often assume that their HIV status will be the same as their female partners. This is what we refer to as proxy testing. So women are more often going in for reproductive health care. They're going to the clinics because they're pregnant or they want to get family planning or whatever, and then they get tested. So it's more often that women get tested. Then men will assume that their HIV status is the same as their female partners. So if their partner is negative, they'll assume they're negative. If their partner is positive, they'll assume they're positive. That is absolutely not true. It may sometimes be true, but it is not always true. So one of the problems is trying to get men to realize that they need to go in to know their status. And the other problem that I encountered in my work in South Africa, and this was an issue in other contexts, but especially South Africa, men who are not married to the mother of their children often don't have access to their children. And there are a lot of reasons why that I can speak to in question and answer time. But so men are very invested in having children and having healthy children and wanting to have the mother of their child survive in order to take care of those children. So these are the things that got me thinking about, okay, so people really want to have children. There's all these problems around HIV about people being afraid to go and test, about people not disclosing to their partners. What are we going to do to address these problems? And so that is really what got me starting to think about the reproductive piece, because most healthcare providers were telling people with HIV, and still do for the most part, telling them, you can't have children, you shouldn't have children. And healthcare providers, like anybody else, are part of general society. They come with their own biases that they bring into their work, and they often will be castigating women who are HIV positive, who get pregnant. So I was sharing with Aisha earlier, like in the Malawian setting, women would tell me about how they'd come in and they were pregnant, they were HIV positive, and the doctors would yell and scream at them, sometimes hit them. And then the doctors wonder why these women don't continue to come in for care. Likewise, when I was starting this work in South Africa, one of the research entities I approached to do this work with, a group at a prominent university in South Africa, said to me in the early days of when I was starting to do thinking about this work, said to me, well, you know that the chair of our ethics committee has said that he feels that women who are HIV positive, who get pregnant, ought to be incarcerated. So that just tells you the kind of attitude toward, I mean, those are just little snippets of the kind of attitude toward people who are living with HIV, who want to have children. But many researchers have started in the 2000s doing this work and reporting on the fact that many people with HIV do want to have children. They have a desire to have children. And once they get onto treatment, it often motivates them because now they're feeling healthy, they're well, they'd like to have children. So, and part of that is that it makes them, as the one title of the paper that I've quoted there says, life is still going on. Makes them feel like, okay, life is normal. People talk about their partners wanting them to have a child. Many times families, parents who want grandchildren are saying, when are you going to have children? And if they haven't disclosed their status, that makes it very difficult. The other thing that's made it a lot easier, besides treatment making people well and therefore feeling that now they could have children, is that we really have improved what is referred to as PMTCT care, the prevention of mother-to-child transmission. And I, again, in question answer, I can answer questions about how that's done, but we've become very successful at preventing the transmission of HIV from the mother to the fetus and to the infant, to the degree that if a woman follows the protocols, there is a less than 2% chance that the child will have HIV. And in South Africa, they've already got that number around 3 to 2% of born HIV positive actually get HIV. Here is the problem. So, not the problem, here's the great thing and the problem. In reproductive health care, people living with HIV who come in for reproductive health care, all of that is primarily focused on the mother and the child. So we're getting women coming in and we're working with them to prevent the transmission to the child. And as I mentioned, 85% of pregnant women living with HIV across the globe are currently accessing treatment to prevent transmission to their children. So we're doing a great job there. Hip, hip, hooray. This is a wonderful thing. Now we get to the gender and reproductive rights part. So, as I've been mentioning, sexual reproductive health care focuses on women. And all the services are delivered anywhere in the world. This is not just in some African settings or so, it's everywhere. It's delivered toward women, it's female-centered. Men are generally left out of the picture, and at best, men are treated as adjuncts to women and children, that they should come in to support their wives and support their children, not that they should come in for care themselves. Now we've got to think about this. There are a bunch of men out there living with HIV. So we need to make sure that we're engaging those men because we want to make sure that their partners who are HIV negative don't get HIV and that their partners then can give birth to children who are living free of HIV. So that's how I came into this around this framework of reproductive justice. To effectively ensure reproductive justice for people with HIV globally, we need to ensure that people living with HIV and couples who are affected by HIV have access to information on how to safely conceive a child as well as to bear an HIV negative child. And literally nowhere in the world are we doing this systematically. We've had research studies here and there. We have little pockets, and I'm talking anywhere in the world, little pockets here and there, but we don't have anywhere where we're routinely doing this. And this kind of gives you a little bit of a graphic representation of how we do this. For seroconcordant, meaning both partners have HIV, we generally inform them that they should both be on treatment. They should be trying to protect themselves using condoms during intercourse, but when they are trying to conceive a child, we refer to that as timed unprotected intercourse, meaning they don't use a condom just during that window of time when the woman is ovulating. So they're keeping their viral load suppressed by being on treatment, and they're reducing the risk by having a narrower window of time when they're engaging in unprotected sex. For a serodiscordant couple, that means one partner is positive, the other negative. If it's a man, ideally you want to do sperm washing. Now that's very expensive, very difficult, not available in most settings. So we have other means. You could use PrEP, where the woman who's HIV negative would take antiretrovirals just during the period of time that they're trying, for the months that they're trying to conceive, to protect herself from getting HIV. Where the woman is HIV positive, we can again ensure that that the positive partner is on treatment, and then we do manual self-insemination, where the man would use a condom without spermicide. Most condoms have spermicide. We don't want to kill the sperm. And then they collect the sample using the condom, and then they take a syringe at home, a syringe without a needle, just a regular plastic syringe, and they take that semen sample up from the condom, and she lies down on the bed and then insert it into herself and lay there for a little while. So basically inseminating herself. And that way he has no risk at all if he's HIV negative. So that's the summary, and I can answer more complicated questions, but that's how we do it. So this is the outcome we want to see. This is a couple in South Africa. She's HIV positive, he's HIV negative, and they've had two beautiful HIV negative children. That's a big win. That's what we want. So what will it take to ensure reproductive justice for those who are affected by HIV? First of all, we need to put the family back in family planning. That means we need men and women there, not just women. We need to work with healthcare policymakers to restructure services to ensure men's access to these services and to care and information. We also need to address provider bias. Providers are people like any of us. They will have their biases, and we need to help them realize that even if they believe that a couple should be married, for example, before they have children, that if a couple is coming to them and they're not married, they still need to provide the services. They can't impose their view that this couple ought to be married. And believe you me, that is a problem in some contexts. We also need to work with communities and community leaders to really address these challenges that people living with HIV and their partners and their families face, and make them realize we can help these families. We can facilitate safer conception. And in a place like South Africa, where 20% of the population is living with HIV, most of those are young reproductive age people, we want to make sure that they can continue to reproduce. We want to ensure that the nation is a healthy nation. And what do medical interventions usually miss? First of all, they usually miss engaging communities and NGOs. They're often working in their clinical settings, doing their great work, but as we've become aware under the COVID pandemic, it's not enough. The science is not enough. People, for many varied reasons, will resist the recommendations that healthcare providers and public health scientists are telling people they should be doing. So we need to work with communities because they become the people who really encourage people to embrace these new technologies and these new advances. We also need to work with the people who are living with HIV to determine what they want and what they need, instead of telling them what they should or shouldn't do, telling them they shouldn't have children. If they want to have children, they sure can. We need to help them. And as I've been saying again and again, we need to work with men. I'm going to wrap this up because there's a lot of stuff I can speak to in questions. I just want to give a shout out to these various people who have been doing very important work in African settings, and as well as in the case of Deb Cohan, she's been doing some of this work here in the United States. She's based at UCSF. And just for you to know, when I send this along, there are some key references here for people who are interested. So I'm going to stop my share at this point, and I'm going to stop talking at you, and I'm going to invite you to ask questions.
Okay, well, let's give Dr. Mindry a hand before we start with our Q&A. That was great. Wonderful, wonderful. So we do have a question here from Ferede. And she says, thank you for an informative and educational presentation, very valuable. I would like to know, as a resident of the city of Pasadena, what is my role? How can I help with this dilemma?
That's a good question. I think we all have to start with where we're at. So part of that is making sure that we have these kinds of dialogues, that we share this information, that people find out, you know, actually there are ways that healthcare providers can help people who are living with HIV to have families safely. It's possible, but people need to go into their healthcare providers and they need to ask for the support and help to do this. And this is a problem right here in LA. I did work on a very small project here in the LA area with a clinic in South Central LA and another clinic in the Valley. And what we were finding is not very dissimilar from what I'm describing. We are seeing in African American and in Latinx communities that there is heterosexual transmission, as well as, you know, there is homosexual transmission, but we're also seeing, fairly significant numbers of heterosexual transmission. And so there are people who need to know that they can have children safely and that they need to seek help. County USC has researchers and clinicians who've been doing a lot of this work very quietly, often they're at their center trying to help people, but more often than not, they get people coming when they're already pregnant, and we want people to come before they're pregnant. We want to be able to help them prevent infection of their partners. Many people still deal with stigma and discrimination in their religious communities, in their communities that they live in. One of the postdocs I was advising did some interviews with some of the people at the clinic in South Central who reported things like the communities they were living in when gangs that were operating in the community found out that they or other members of the community had HIV, they would chase them out of the community. We don't want that to be happening. So we really need to start creating an environment that embraces people living with HIV. This is not a death toll anymore. And people really can have good family lives. So I think it's really important to get that message out here as much as it is important in these contexts that I've done work in.
I have a question, Dr. Mindry. I was wondering why, when you gave us the percentages, I was wondering why the rates were so high in Southern and Eastern Africa.
Okay, so we don't fully understand. There are a lot of theories. I can tell you in South Africa, one of the reasons why is that the HIV pandemic was just kicking in right at the time that South Africa was transitioning to democracy. And Nelson Mandela at that time had advisors who were drawing attention to the need to attend to the growing HIV epidemic in the country. But so much of his attention was focused on the transition to democracy and insufficient attention to really getting on top of the HIV epidemic. And we know here, politically with the COVID pandemic, how the politics really can impede the effort to do what we need to do. And just like we dealt with here with COVID, where when our numbers started going high, you get large numbers of people living with an infectious disease, they're going to infect more people. The numbers are going to grow and grow and grow and grow. It's exponential. So what you need to do is be able to get on top of an epidemic early, an infectious disease epidemic early, to contain it and to have as few people as possible living with that disease, because the more people you have living with that disease, the more opportunity there is to spread it. In Southern and Eastern Africa, there have been many theories that some of that has been because there is a lot of trucking. There's a lot of truck trade that happens, transportation of goods throughout Southern and Eastern Africa. And so one of the theories has been that truckers who were traveling and were then having sex with sex workers along the route were part of the problem. So some of that is about this travel of truckers who were then taking the disease back and forth. Another part of this is migrant labor, because South Africa is a place that attracts labor from all over Africa, especially Southern and Eastern Africa. And so South Africa had very high rates of infection, and you find that people who are coming to work in South Africa and then going back home are taking HIV back home with them. There were theories also about that these regions are regions where there used to be polygynous relationships, men who had multiple wives, but under colonialism, those kinds of structures were broken down, where Westerners and particularly Christianity placed an emphasis on monogamy. And so now we have a system of polygyny operating, but it's not polygyny where it's formal, where you're actually getting married. So in one of the theories has been that in much of West Africa, you still have polygyny in place, where men will have legal more than one wife. And so then you get this kind of closed circuit. If someone within that network has HIV, they're spreading it within that network. But where you have an emphasis on monogamy, but still practices of polygyny, of having multiple partners outside of marriage, then you get the opportunity to spread it to other networks, people who are connected sexually to other people. So, there are arguments back and forth about whether that's correct, but that's one of the theories.
Thank you. I think Walam was next.
We can't hear you, Walam.
Thank you very much. It was a great presentation, Deborah. Question, does or did the Institut Pasteur in Dakar be involved in this and to what extent?
Sorry, does what? In Dakar?
Institut Pasteur in Dakar, his involvement in
I don't know. I have not done work in Senegal, and I don't know the extent to which they're involved in this work. As I pointed out earlier in the presentation, the rates of infection in Senegal are very low comparative to many parts of the world. So it's not, there have been other infectious diseases that have been of greater concern in Senegal than HIV, but I'm really not an expert on the Senegal situation. So I'm sorry, I can't speak adequately to that, or certainly not in a truly informed way about that.
Thank you.
We have a comment from Honorable John Kennedy. Would you like to read it, or would you like me to read it?
Okay, thank you, Dr. Mindry, for your presentation. Certainly, we've been looking forward to hearing from you, and certainly Walam is what I would call your chief advocate. So Duma Sani was a friend of mine. I first met him at the anti-apartheid conference at Hunter College in New York. And it is somewhat a surprise to me that you shared with us the cause of death was HIV, given that the official Wikipedia and other areas have reported that it was asthma. And if that is true, do you think in part the reason why a successful Black male leader in South Africa would not want to have been known to have died of HIV and its complication is because of the kind of ignorance the president at that, I don't know if that's correct at the time, but let's call him President Jacob Zuma had advocated in the country.
Okay, I'm a little bit confused. Who are you talking about who died?
I thought you had mentioned Dumasani Kumalo, no?
Oh, no, this is Xolani Khumalo. He was somebody that I was working with. No, not Dumasani, Xolani. No. And he was a man that I was working with who was part of the Ujamaa Center in Pietermaritzburg.
Oh, yes, I know that center.
He was one of the people doing outreach work. He eventually did not actually, he died of AIDS. He actually got, this is somebody who was very close to me and the work I was doing. And he was a very strong advocate. He worked with men. I was telling Aisha earlier today, he was a wonderful man who I feel has been a great loss for his community, which was the community of France, just on the outskirts of Pietermaritzburg. And he did outreach to support groups, and he led support groups for men. And he really got men engaged in making change. But he unfortunately contracted TB. And when you have HIV, TB can show up and affect many varied parts of your body. Like we usually think about TB in the lungs. But when you have a compromised immune system like an HIV positive person has, it can then infect other regions of the body. And he got TB in the abdomen, but we don't have very good ways of detecting TB in other parts of the body. By the time the doctors figured out what was going on and why he wasn't well, the TB infection had gotten so bad that they could not actually turn him around, and he died. So this is a colleague of mine that I was working with, not the person you're referring to.
Okay, and since I'm asking that question, the follow-up was not to concentrate on Duma Sani, but was to concentrate on misinformation in the country, particularly when the president at the time would say some of the most outlandish things about how you could prevent HIV transmission, etc.
Right. You're absolutely correct. So as I mentioned, and I didn't give the full history, we started to be aware that there was a problem with HIV under Nelson Mandela. And he was so focused on the transition to democracy that he was unable to attend adequately to it. He was then followed by Thabo Mbeki, who then partnered up with renegade scientists actually from UC Berkeley, believe it or not, who were making an argument that there is not a connection between HIV and AIDS. And so he was very much in denial. And some of Thabo Mbeki's arguments really came from a place of questioning colonialist interpretations of what was going on. And he was trying to forward the theory that really what HIV, what causes AIDS is poverty. And we do know that if we look anywhere in the world with any kind of infectious diseases, the populations who are most vulnerable are the poor. And in most settings, those people who are poor, whether they're in other parts of the world or here in the US, are people of color. And so it's about access to adequate health care. It's all those factors that really drive things. And to some degree, Thabo Mbeki was trying to latch onto that, but he did it in this really, really fumbling kind of way that did this denial of the connection between HIV and AIDS, instead of saying, well, yes, there's a connection between HIV and AIDS, but we also have to attend to the role of poverty in this and get then on board with how do we address the role that poverty is playing in this. Instead, he went to the place of resisting getting treatment out to people in South Africa. And because we were not treating people living with HIV, just as I said earlier, an infectious disease will grow and grow and grow. We saw that happen with COVID here. You don't interrupt it, it will just explode. And by the time we got people really attending, and although Jacob Zuma is a highly problematic person in lots of ways, Jacob Zuma was the first president to test for HIV and tested HIV negative. And he ensured that antiretroviral treatment was rolled out in South Africa. So, and he's no great hero. There are lots of problems with Jacob Zuma, but he was the one who was instrumental in ensuring that treatment got rolled out.
Thank you very much for your.
Nodding his head.
Yeah. Yes.
Thank you.
I know the Ujamaa collective in Pietermaritzburg.
Oh, you do?
Yes, I was their guest in 2011 for a lecture, and then with the Father Philip Denis.
Yes, yes. And Simango Kumalo.
That's right, Kumalo. That's right, exactly. Yes, yes. And Gerald West.
Yes.
Gerald West. Yes.
That's right, and Gerald West. Yeah.
Exactly. Yeah. Thank you for this wonderful lecture.
That I worked with, and Golani Kumalo, I was referring to, worked for the Ujamaa Center.
Oh, really? Okay.
A great man, a wonderful man. Very sad to have lost him.
Okay. So just to talk about today's situation, I mean, we have a pandemic today.
Right.
And just a few weeks ago, this scandal just broke out around mismanagement of funds.
Right.
For combating COVID, which again, I think is such a sad situation because embezzlement and corruption really siphoned some of the funds, you see. I mean, yeah, very tragic. And under the, I mean, you know, the guidance, I mean, under the administration of a man who had done well as a medical doctor with HIV, Zwelim Gize, but who now, being the Minister of Health, really has seen this situation happen and is what? I mean, this is really terrible.
It really is. It really, really is. And I think, You know, this is why I was saying we really have to engage communities, community leaders, NGOs, when we're trying to do this public health work wherever we are, because there always are politics as well as social issues that get in the way of delivering the care that we know needs to be delivered. And so we can't leave this solely in the realm of medical science.
That's right. Yeah.
You know, and that's in my book, that's one of the main arguments I try to make is, you know, a lot of people in the medical world now around HIV really go by this mantra of test and treat. We need to test people for HIV and we need to get them on treatment. Now, I'm not arguing that that's not true. Yes, of course we need to do that. But what they're doing is they've cut off any of the work focused on behavioral and social interventions, because their focus is on how do we just get people to test and treat. Well, even though they've focused on that, we find that people still do not come in and test and still do not take their treatment, or they get given treatment, they take it home and they throw it away. You know, when I was last in South Africa, I connected with another person from the Ujamaa Center who at the time I was doing work was doing outreach with Xolani. Her name was Nogutula Giela, and Nogutula lost her job because once all of this started to happen, the funding, the international funding for support groups disappeared, because now the focus is on we just need to get people tested and treated. So at the time that I recently met with Nogutula, she was working at a clinic, basically a number cruncher, entering numbers of people who were testing, people who were getting treatment, and so forth. And I picked her up from work and we were driving to her home, and we stopped at a local convenience store to pick up something to eat and drink. And when we were checking out, she got chatting to the cashier. And then when we got back to the car, she said to me, you know what? That woman was in my support groups back in the early 2000s when we first started, when we had no treatment available. She has HIV and she is still living. This was 2018 or 2019. She's still living.
I have a question.
Okay.
Dr. Mindry. You spoke a lot about, I hear the word coming up, antiretroviral therapy.
Yes.
What is that, and how is it successful, and why aren't we doing it here in the United States?
Okay, we are doing it here, and I'll speak to that in a minute. Let me finish this story quickly. So what happened with Nogutula, what Nogutula said to me is, now I'm working at the clinic and I see people who are testing, getting treatment, and then they're coming back later and they're dying because they're not taking their treatment. And there are lots of reasons why. They're afraid to disclose to partners. They run out of medication, all kinds of things. So my argument there is we really need the work in the communities to ensure that even when we have treatment available, that people are taking their treatment. To your question, Gary, antiretroviral treatment is actually a cocktail of multiple different drugs that they've put to, they call it HAART now, highly active antiretroviral treatment. And it's a cocktail of different drugs that help to suppress the virus. And it works in multiple different ways in the body to prevent the virus from replicating, as well as to kill off the virus. And we actually have multiple different regimens because after a while, if someone's on treatment for a long period of time, they will actually develop resistance. And so then they need a different line of treatment. We also know that women who are getting pregnant need to be on nevirapine, which is a particular antiretroviral drug that will not cause any birth defects. Some other antiretroviral treatments will cause birth defects. So there are numerous drugs now that are available, but only for countries like in Southern and Eastern Africa through public health clinic sites that are available. So they can't always get any kind of treatment, only those available through the public health sector that are at a discounted price. And that kind of treatment is available here in the US, but I was shocked when I was looking at the data here in the US before this talk, that we still are not doing anywhere near as good of a job as many Southern and Eastern African countries are doing in terms of getting people on treatment. And there are lots of different reasons why here in the US that will be specific to different populations in the US. And we're not even reporting the data, and I couldn't find out why. We're not even reporting the data on how many people in the US are actually on treatment. You know, it's a relatively small percentage of our population here. And so people aren't making enough noise about this here.
Dr. Mindry, we have some comments.
Okay.
The first one is from Marcela Hernandez Pons. She says, great job. It's incredible that so many years into this terrible disease, we continue to have the same struggles. So much more work is needed to fix this problem. Appreciate your commitment to the education and dissemination of information. She goes on and says, lack of access to doctors, not enough education in school as preventative measures, macho stereotypes, and not enough empowerment for women to say no to sex without protection. And that brings me to one of my questions. I wanted to know, what are some of the trends for young people ages, I want to say 18 to 20, but we need to take it lower than that, just from maybe middle school on up?
Yeah. So one of the things you need to understand in the US, first of all, is that once treatment got rolled out in the US and we were able to contain the spread of the epidemic, it was no longer, it was downgraded from no longer being an epidemic to being a chronic illness in the United States. So HIV is now seen as a chronic illness in the United States. That has real implications in terms of what kind of funding is available. In the US, that means that federal funding does not go toward public education if it's not an epidemic, because it's a chronic illness. And so now it's just a matter of individuals going into their healthcare providers to get care and treatment. So we don't have the funds behind public education anymore. And you'll notice, I mean, there was a time, some of you who are older like me will remember a time when there were billboards everywhere and on buses and on everything saying, you know, do this. And we still see in certain communities, we are seeing a little bit of that in low income minority communities. We are seeing a little bit of that kind of public health messaging. But there's not any systematic education of children in school around HIV. When I have taught students about when I've taught students about sexual reproductive health at the college level, and I ask them about what they learned in school about HIV, many of them had zero education around HIV when they were in school. Some had maybe one class in which HIV was addressed, and very, very few had any, almost no students had any comprehensive information about HIV. So we're not educating the younger generation, bottom line, about HIV.
Right. So we're going to wrap up. I just wanted to acknowledge a couple statements. I'm not sure we'll be able to answer them, but we will make sure that we forward them to you, and maybe you can answer at a later time, maybe through email or something. There was a question there was a statement from Mona Shagoli, and she says, thank you for a very informative talk, Dr. Mindry. Thank you, organizers. Then there is another message from Antresha Averett, and she said, can you tell us how the virus started and when the first case was recorded? Phyllis Chastain asked, are the treatments free and or affordable? And then Sheriff Keita said, thank you, Dr. Mindry, for a very informative talk. Hello, my friend Jim Berry, Molly Watch, and my cousin Abu Bakar, and nice meeting you all. See you in August. And that was about it.
Yeah.
But
Well, I'll take the quick, easy question to answer.
Okay.
Phyllis's question about free and affordable. So depending on the settings, yes, treatment can be freely and affordably available through public health settings. But if you're going to a private doctor, you may be paying a different rate. And US healthcare system, high income countries pay a lot more for the drugs than low income countries. And there was a long battle fought over this issue that South Africa played a key role in, as well as Brazil and India. Much like this whole fight over the availability of COVID vaccines. So that's a whole nother talk in itself. And there was another question that was, about the origins, which is also a much longer question to answer, but you're welcome to share my email. And I will also share the presentation, and happy Boalem for it to be distributed to those within the network, within the group. And happy to field any questions via email to people and who want to follow up further.
Well, thank you so much, Dr. Mindry. This was a very, very informative evening. Let's give her a round of applause, everyone.
Well,
round of applause.
Paul. It's been just such a pleasure to talk about this. It is, as you mentioned, a great passion of mine. So lovely to have the opportunity.
Wonderful. Do you have any closing remarks, Boalem or Ms. Lena?
Myself. Thank you very much, Aisha, for being the MC. And of course, Deborah, you were magnificent, and we expected that from you. Thank you. I'm very happy to see everybody here. But